Okay, I'm going to run through Neuro Assessment with you rather quickly. It's not a difficult chapter at all. I just want to point out a few things. So this is just a reminder of the different areas of the brain, and I love that picture on the left that's showing you where it's physically located according to the body. And then I also like the picture on the lower right that's showing you the different lobes and what you primarily think of. It is important that you at least know generally what each lobe does because that will help you as you answer questions on the test. Excuse me. So I'm really just going to cover those lobes quickly and then you can look at the rest of the detail. The frontal lobe. When you think of the frontal lobe, think of judgment and reasoning. Things like problem solving. When you think of the temporal lobe is processing. So receiving, data, visual, auditory data, and then understanding it, interpreting speech and language, that kind of stuff. Parietal lobe is a sensory cortex primarily, and then occipital is primarily sight. The other thing that's really important is the brainstem. The brainstem, remember, controls your respiratory rate and your cardiac function, and then all the messages kind of coming out of the brain, so very, very important. And then lastly, the cerebellum. When you see a problem in the cerebellum, you need to think about balance and coordination is usually the problem, and so that makes them a fall risk if they have a problem in the cerebellum. Now, a lot of this I'm just going to fly through, and I would have done this in class too because a lot of this is patho that I'm just not covering anymore. So we'll talk about acetylcholine and dopamine as we talked about it. Well, we already have talked about it with chronic diseases. The peripheral nervous system, also, you can review that to remember what each area does. The cranial nerves, you do not need to know them again. I'm sure you're happy about that. You don't need to know how to test them. But I would like you to think about which one's the most important, and that would be 9 and 10, the glossopharyngeal and the vagus, because of the gag reflex and the potential for aspiration when we have a problem there. The vertebral column will become a lot more important next quarter when we get to spinal cord, so we will review it a little bit when we get there. Now we're to the meat of the chapter at the assessment level. So I will go through these in a little more detail. So cerebral function is assessing mental status. So that's looking at things like what's their general appearance? Are they clean? Are they well kept? Or do they look slovenly? Do they look like they're not cared for? And then what's their general behavior? It's also cognition. Remember the mini mental status exam, and we asked things like count backwards by threes, or remember these 3 words and repeat them later. It's looking at your cognitive function. And then mood and affect. Affect, remember, is what your face looks like. So if my face is very flat and non-expressive and I'm telling you a joke, that affect does not fit with my mood or my demeanor. So we say I have a flat affect. So we talk about affect quite a bit. The cranial nerves, we've already kind of run through that. As nurses, we don't test the cranial nerves. You will see physicians do it, especially neurologists do it, but as nurses, we generally don't do that. The motor system, this is looking at muscles, so muscle tone. So weakness, one of the ways we can check is by this picture you see here, which we call pronator drift. You have the patient put their arms out straight with the palms up, and then have them close their eyes, and if they cannot keep their arm up, if one drifts down like you see here in this picture, that's called pronator drift, and that's a positive pronator drift telling us that they have weakness in that extremity. We also look at muscle tone, and here I usually write words on the board, so you're going to have to kind of just listen to make sure you understand turns. So hypotonia is flaccidity. Hypertonia is spasticity. Myoclonus is muscle spasm. Myo is muscle, clonus, spasm of the muscles. Athetosis is a involuntary movement of the extremities. It's kind of like a writhing, almost snake-like movement. And then chorea, we've talked about before, that's Chorea. Chorea is movement, usually a rapid, purposeless movement that the patient can't control. Remember the little girl we watched that had Sydenham's chorea, that it's like that. And then lastly, dystonia. Dystonia means an impairment of the muscle tone. Balance and coordination, or cerebellar function. Remember, the cerebellum is about balance, and if we have trouble with that, then we have a safety risk. So the picture you're seeing here on the right is Romberg's test that you see listed a couple of lines down. Romberg's test is where you have the patient stand with their feet together, like you see on this picture, close their eyes, and then it's considered positive if they lose their balance. So you see how the guy has his hands next to him? That's a safety thing, just to make sure that if the patient starts wobbling, you've got some support there. So oftentimes, a lot of times people don't know that their balance is off, but then when you have them do this, they get real wobbly. So this is a very good test to do. If it's a positive Romberg's test, that means they are a fall risk, and you need to be able to apply that. Sensory, touch, pain, temperature, and vibration. Think about how you test for those. And remember basic rules. If we're going to do sensory testing, this is what you kind of learned about as, do you feel me touching? Tell me where you feel me touching on your toes. How about this? How about that? So the rules are, you don't ask them leading questions. Like, don't ask them, is this sharp? Instead, you say, how does this feel? Sharp or dull? Soft or firm? Whatever it is you're asking. You always have them close their eyes so they don't know where you're touching or what you're touching with. And you make your pattern random. You wouldn't touch the toes in order. You would randomly touch and ask them to tell you where you're touching. Also, sometimes we will test pain. Pain ought to be the last thing you test, or they might not want to play your game anymore. So do like soft touch and light touch, and then if you need to do pain with like a tip of a needle, it's never big pain, but slightly painful, then you ought to do that last. That's all. Oh no, reflexes. The reason I put reflexes on here is because you don't always remember the numbers. So 2 out of 5 is normal reflexes. 0 out of 5 would be no reflexes. And then 5 out of 5 would be hyperreflexic. So 2 out of 5 is what we would consider normal. Now, different diagnostic studies that we would do for neuro, I do want you to know these, and this is really primarily what we're going to talk about. So this is a quick run through. CT, you know generally what that does. MRI, you know what that does, and you know the rules. No metal, no pacemakers. It's not radiation, it's just noisy. MRA is an MRI with an angiography. So this gives you very detailed pictures of the blood vessels and requires contrast. The PET scan, PET measures metabolic activity in the brain. So you use a radioactive material and it shows metabolic activity. So we do that through an IV line. Oftentimes what they'll have them do is some sort of activity. And so maybe have them read something or memorize something, and then they watch to see where the activity is occurring in their brain. SPECT is very similar. It looks at blood flow. So oftentimes we're doing these, we're looking for neurovascular problems like dementia causes, Parkinson's, tumors, that kind of stuff. Excuse me, ultrasound. The ultrasound we would do for the brain oftentimes is a carotid ultrasound, which usually people are kind of like, what? And it's because the carotid is the big vessels that are feeding the brain. So we do an ultrasound to see if there's any narrowing or thrombi there. And then the other thing we might do is a transcranial Doppler, where we would use a Doppler, which is just a mini ultrasound, over the vessels in the skull. Again, for the same reason, to see patency of those vessels. Cerebral angiography, remember the angiography is where we put dye in a vessel and look at flow and look for narrowing or blockage. But we have to get to the vessel. So all of them typically are done through a cardiac cath. So we do the cardiac cath procedure and then we thread up to the vessel we want to look at. So in this case, they would thread up to the carotid arteries and then look for flow. So you have the same risk as you would have with a cardiac cath. You have a risk of bleeding, you have a risk of clotting, and then of course you would lay still, straight-legged for an hour, for several hours, and you do vital signs. In addition, you have a risk of causing a stroke because you might loosen some emboli, loosen some thrombi, and make them emboli that could then go to the brain. So we got to watch for stroke symptoms. Lumbar puncture is a spinal tap. We're going to cover that in detail. Myelogram, EEG, and EMG, all we're going to cover in detail. So here's your lumbar puncture. It's done by the physician. Your job will be to assist with the procedure. It is often done in the patient's room, at their bedside, or in a procedure room. It doesn't need to be done in the operating room or in some special radiology department. Just the patient's room or procedure room. And what the doctor does is they do just a local anesthetic in their back, and then they insert a needle into the space between two of the vertebrae. And there's specific vertebrae they use. It's not so important you know that unless you're responsible for like positioning, like putting numbing cream on, something like that. So now in children, we oftentimes will sedate our children for this procedure just because we're peds nurses and we're nicer. But most of the time people don't sedate for a lumbar puncture, or as the public thinks of it, a spinal tap. We just do a local. So if you're not sedated, you don't need NPO, anything like that. Now, when they do this, the nice thing is they can do lots of things with it. So the doctor puts the needle in, and you can see in the lower right corner the needle, and there's fluid, cerebral spinal fluid, just dripping out. So often we're doing that to get a culture, like if we suspect meningitis. And so they get in the space, they allow the fluid to drip out, and there's actually usually 4 or 5 of those little vials you see there. So your job as the nurse is to hand those vials to the doctor and then label them as they come out. So we label them 1, 2, 3, 4, put the patient's name on them, and send them to the lab. So you just hand them, the doc drips a few drops, and then you hand them the next vial, and they drip a few drops. While they're there, if they needed to, they could give medications through that. So like with leukemia patients, we do an LP looking for cancer cells, and then the doctor will administer chemotherapy that way. And that's called intrathecal medications, and physicians do that. They can also inject other things, anesthesia, things like that. Now, what you see to the left lower picture is a measurement of pressure. So while they're there, they can put a little manometer, and it actually is, 12 inches long. That glass part, it looks like a thermometer, but it's pretty long, and they just attach that to the end, and it allows them to get a pressure reading for intracranial pressure. Now, the one really important thing about this test is you never do it if the patient has a risk of high intracranial pressure, which we will cover in Med Surg II, which conditions those are, so that you can be very clear. But you want to remember that, because what can happen is we release the pressure out too quickly by putting that needle in, and it can cause the brain to get sucked down through that opening up by the skull and cause herniation and death. So it's kind of a big deal. I didn't mention in the upper left corner, the picture shows the proper positioning. The patient is usually on their side in a C position. So they're curled up. That allows those vertebrae to open up so that it's easy for the doctor to get the needle in the correct place. This is pretty rare to have complications. It's kind of terrifying to get a needle put in your back, but there are very few complications with this. The patient may feel tingling as the doctor gets this in place, which is kind of scary. They can feel pain kind of down their leg, but that's a very temporary thing. The care afterwards is also important. All they do when they take that needle out is just put a Band-Aid over the site. No big deal, not a lot of pressure, just a Band-Aid. And then they usually will have the patient lie flat for a few hours just to prevent a spinal headache. You've heard that before. Spinal headaches are more common if we take a lot of fluid off or we're injecting much into that space. Not so common for just doing, kind of cultures. But that can happen, and the best way to prevent that is to get lots of fluids afterwards, and they don't typically get too much of that. There is a potential complication for infection, a potential risk for a cerebral spinal fluid leak, but again, these rarely happen. The myelogram, what you should know about this is that it's an x-ray of the spinal cord. And it does require a lumbar puncture. So the patient goes down to the radiology department. They go ahead and do the lumbar puncture there in the radiology department. They'll inject contrast, so you do have to know if they have any allergies to iodine or shellfish. And then they put them on typically a tilt table, and they let that fluid run, the contrast run up and down the spine, and then they look for areas of narrowing like you see on the far lower right. And so again, it does require the lumbar puncture to be done, so it is slightly painful. And sometimes patients need sedation to do this. They are more likely to get this spinal headache and maybe even some nausea, vomiting afterward, probably because of the volume of fluid we put in with that contrast. So again, lying flat will help with that, getting lots of fluids. The EEG and evoked potentials, very similar tests, but they're done for different reasons. So the EEG is an electroencephalogram. It looks at electrical activity in the brain. It is purely a reading, like our EKGs, just a reading of the electrical activity. There is no electricity that flows through these sensors at all. We mostly do this to diagnose seizures. We also can diagnose brain activity, and we might do this for sleep issues, sleep problems. It is truly non-invasive. It looks invasive, but it isn't. All that is little electrodes that are glued on. So it is stinky, like they use a really strong glue that smells a lot, and then that glue gets in their hair, kind of hard to wash off. So that's how it works. The one rule generally is you can't give them sedatives, or sometimes there's seizure medicines before you do it because you want to see what the brain activity is. So that's EEG. Now, evoked potentials. The reason I'm showing you the little babies on the far right, besides the fact that I just love babies, is that most of the time when we're doing evoked potentials for brain flow, we're looking at hearing and vision. So in patients that can't do testing for us, like these little babies, we can evoke some activity. So we look at the electroactivity in response to some sort of stimulation. So like your little baby there on the right, they're testing hearing. So if you look, they've got little earphones on, and they're sending sounds to those earphones, and then they're looking at the brain activity to see, does baby respond to those sounds with brain activity. Since we can't tell them raise your right hand, raise your left hand, we're looking at that activity. Same thing that you're kind of seeing with the baby above. Again, we're going to either maybe flash lights to test vision, or do sounds to test sounds. Other than that, it looks a lot like the EEG. We're just looking for different types of responses. And there are some other evoked potentials we'll talk about with other body systems, somatosensory, where we stimulate nerves and then see how the body responds. So that's EEG and evoked potentials. The last one, I think, is EMG. The important thing about EMG is that it's painful. So it's for electromyography, and we use it when patients have unexplained muscle weakness. And what they do is they put typically electrodes, needle electrodes, directly into the muscle, and then they will ask the patient to contract their muscles and look at the electrical response to that. Sometimes they will do a stimulation, electrical stimulation, and see the response. Now, what you're seeing on the far upper right are little, instead of electrodes, they've got little sensors, so that's not as painful. But EMG traditionally is needles into the muscles, and we can't sedate you for that or give you pain medicine because we're trying to see how the muscles respond to stimulation, whether it's muscle contraction or electrical stimulation. So nothing is actually injected. They just put the needles into the muscle, which feels like an IM injection, and then they leave it there, stimulate, which could then cause the muscles to be sore for a few days. So important to know that it's going to cause some pain. I think I maybe have a couple of questions that I'll cover. During a neurologic assessment, the nurse obtains most of the data related to mental status. 1, during the nursing history. 2, by asking the patient specific problem-solving questions. 3, by noting behaviors while the patient's unaware of the nurse's presence. Or 4, by asking the patient to complete a written standardized mental exam. So what's really important here is that as you talk with patients, just through the course of your conversation and your full assessment, you get a lot of information about their mental status, their cognition, their ability to answer questions, follow directions. So some of these others certainly we might do, but you get a huge picture by just doing your history. When assessing cranial nerves 3, 4, and 6, the nurse should 1, test the patient's eye movements. 2, ask the patient to smile and frown. 3, have the patient stick out his tongue. Or 4, touch the patient's posterior pharynx with the tongue blade. So, yes, I told you, you will not need to know the cranial nerves. I want you to see that even though you didn't memorize, you probably know this one. So, what nerves do we test 3 at the same time? And most of us will remember that's those eye things, the eye movement, where they follow the fingers, you ask them to move, that kind of stuff. All right, that is it.